And the next talk is by Dr. Francesco Pichi, and the subject is the art of interpreting images.
Promise it's my last talk. So I just told you in the previous presentation that OCT is basically the Swiss Army knife of an ophthalmologist. We could diagnose stuff just by OCT. Now I'm going to tell you the opposite, basically. So I'll just start by presenting cases. We've heard a couple of beautiful talks on VKH this morning, and we know that subretinal fluid, the presence of a bacillary layer detachment, the loss of choroidal vasculature, the RPE, ondulation, they're all signs of VKH, and here they're present, for example, in every scan. Then we heard about the pinpoint leakage in FA, and this is quite typical. Now I'm going to present you 3 cases, and OCT here in all cases is pointing at subretinal fluid, loss of vasculature, maybe bacillary detachment, bacillary and subretinal fluid, loss of vasculature. So is everything here a VKH? Let's see which one is actually a VKH. So, sorry. I'm going to start, for example, with our first patient here. Now, the first patient, you can see straight away in the fundus has some placoid lesion. So at this point, if OCT is not giving you the correct diagnosis, you go for dye testing. In dye test, you see something that blocks early in FA, stains late. So this is quite typical of AMPI, and the ICG is showing us the choroid and chorocapillaris non-perfusion. Moving on to the second patient. Now, in this case, there is a lot of subretinal fluid, and the fundus photo is showing it. Now, we got more pictures here. Now, in the dye test here in ICG, you can see that there are areas of hypoperfusion that are not as much demarcated as the AMPI one that we saw before, and this is a case of posterior scleritis, where, for example, a B-scan would tell you the diagnosis. Finally, this patient has a thin layer of subretinal fluid, and by performing our dye test, you can see that there is pinpoint leakage here on FA and hypo spots on ICG. So indeed, this is the case of VKH. What about this other eye? So OCT, as I told you before, is showing you some cells which could be consistent with VKH, the subretinal fluid, the choroidal loss of vascularity, but the patient is 75, and this is unilateral. So 75-year-old patient, what is the most likely diagnosis when you have something unilateral and loss and this particular appearance? Well, you want to know more about this patient. In FAF, you have, this is not the correct term, but you have kind of that leopard spot pattern of hyper, and this is reflected also in FA early, and in late FA there's diffuse staining, and if you look here on your MRI, you got a beautiful mass, and this is a case of choroidal lymphoma. One more. Now, this is an easy one, maybe. Here you have some fibrin between the retina and the RPE. What is the most likely diagnosis? You can see it here, the hot spot growing on FA. So this is a case of central serous chorioretinopathy. Is this case then another case of central serous? You have some fibrin here, you have your beautiful SRF, and it's quite typical, I would say. But if you examine the patient carefully, you can see there is some kind of intermediate uveitis, some kind of vitritis. And looking at the patient, there is leakage all around, and the patient is young, she's female, and she has MS. So this is just subretinal fluid complicating the case of MS, intermediate uveitis. Now, this is a 55-year-old female that has some cells in the anterior segment. And you can see subretinal fluid again. Now, is this subretinal fluid coming from some kind of uveitis, or what is the most likely diagnosis? Now, here the choroid is very thin, so I wouldn't worry about VKH in this case. It could be anything of these cases, but it's actually a retinal detachment that's causing spreading of the photoreceptors, and actually the patient has kind of Matsuo syndrome because the pressure is high. Now, moving on to the outer retina. OCT in the outer retina, I showed you before how AMPI, for example, gives you this hyperreflectivity and edema of the outer nuclear layer. So are all these cases of AMPI? No, these are all cases of different pathologies. And so this is why OCT is great. I love OCT, but we need to analyze better. So let's start with this patient here. You can see the hyperreflectivity, which is affecting the photoreceptors and going into outer nuclear layer. If you do a couple more pictures, what do you see here? You see a case where OCTA is showing us non-perfusion, which corresponds very, very well to the ICG one, and you see the classical early block and late stain. So this is the patient improving with treatment, and this is a case of AMPI, which I tend to treat, especially when it's central with steroids. Now, moving on to this second patient, same appearance as before. Photoreceptors are fuzzy and hyper. There's hyper of the outer nuclear layer. It's not in the center, maybe it's slightly by the side. So let's examine what the patient has. This is pretty typical. I'm not even going to tell you what it is because it's super easy after seeing all these beautiful pictures, although this beautiful presentation we had before. ICG is showing the non-perfusion. FAF in this case is very useful to diagnose and follow up, as Dr. Vishali showed us, this case of serpiginous choroidopathy. One more case, again, fuzziness of the photoreceptors, fuzziness of the outer nuclear layer. This is all the same appearance on OCT, but if you look clinically, then you can see there's a bleeding, there's a hemorrhage there. So this is probably a case of some kind of occlusion, where infrared is telling us there is some kind of occlusion of the deep vessels inside the retina. This is a case of acute macular neuroretinopathy. What about this one? This one looks quite different. You have your RP, which is bumpy. You have hyperreflective material, which is obscuring the photoreceptors. This patient, you can see straight away, maybe, yes. You can see straight away in the periphery, you can see the classical appearance of a primary vitreoretinal lymphoma with all these lesions shifting. This OCT appearance can be quite typical of a lymphoma. My opinion, humble opinion, is that the lymphoma cells, they come from the choroid. Sometimes they go under the RP and then inside the retina, and sometimes they tend to go all the way to the vitreous. So this is a case of vitreoretinal lymphoma. And is this a case of vitreoretinal lymphoma? When I saw this patient, I said, yes, this really looks like a case of vitreoretinal lymphoma with this hyperreflectivity, and which is between the RP and the photoreceptors. And the patient is actually looking on OCTA, has a kind of non-flow at the level of the choriocapillaris. On autofluorescence, you don't see a lot. Maybe you see a diffuse hyper autofluorescence here. ICG is showing us some hypoperfusion in the center, and what's quite telltale in this patient before getting any test is this plaque of hyperfluorescent in the macula with the edges that are slightly leaking. So these are the hands of the patient, and this is a case of placoid syphilis. And this is the patient actually the 2 days after. So I think, I don't remember who, you presented this morning the case of syphilis, and you have the RP bumps. So the RP bumps, they appear in the placoid syphilis a couple of days after the initial diagnosis before treatment. So these are the correct diagnosis for these OCT, which actually look more or less the same. So another final case, we were talking about mutes. We heard a lot about the granularity of the fovea. Now these two patients, they look very similar. There is some fuzziness of the photoreceptors here with an RPE mottling, and same here, except that one is mutes, one is retinopathy from Popper. So to me, the second most important test when you have mutes is autofluorescence, except of course when you do fundus photo. Now this case is typical of mutes. When we saw it present with the dots and spots which are hyper because the RP is getting more exposed, and this is a typical Popper retinopathy. And I thank you for your attention.
Thank you. That was a wonderful set of talks. I would invite a few questions from the, yeah.
Wonderful talk, Dr. Pichi. I want to ask a research question. You told in previous talk that APMPP has choriocapillaris involvement and sometimes some cases with CNS small vessels involvement. Now, and you have shown a fractal OCT there. Now, was functional MRI was done in all those cases of CNS involvement in?
No. So the working diagnosis is that MP is some kind of vasculitis of the small vessels, so it's affecting the small vessels of the brain as well. So in the research paper that was just published, they didn't do any functional MRI.
Okay, my second question is that you see in macular OCT in Parkinson's disease, now just there is a foveal pit is thinner and RNFL changes are there in the, and if you see just the foveal pit which is depressed in Parkinson's disease and some CNS involvement is also there, do the choriocapillary changes, are there any evidence out of it comparative with the?
In Parkinson, you mean in Parkinson?
Choriocapillaris layer?
I'm not sure. I don't know if the others know anything about this, but I'm not sure.
Okay. Thank you.
I have a couple of questions for you. So one of your papers of granuloma, where you described the blood vessels versus smaller granulomas, a backscatter, that paper was based on EDI-OCT, which doesn't actually image the CSI, till the CSI. It uses kind of a technique to image that. But when you image the same images with an SSOCT, you don't generally get those scatters. So how do you differentiate on the SSOCT?
So me and Alessandro, we've been fighting a lot about EDI-OCT and the detection of granuloma, because the paper on retina says, yes, with EDI-OCT, if you scan through all these OCT, first of all, the paper on retina was based on comparison between ICG and EDI-OCT. So you're getting an ICG, and then you're scanning one by one and looking at the granulomas, and you see the hyper halo behind it. And then since we were fighting so much, we decided to use OCTA. So OCTA is very reliable in detecting the granulomas. So if you compare ICG and OCTA, we measure them one by one, scanning OCTA at the level of the choroid. There's a perfect correspondence between the void in OCTA and the hypo lesion, which corresponds to a granuloma. So I believe that if you have a good OCTA, you don't have to do an ICG, a serial ICG to monitor the follow-up to the patient. You can get away with one ICG and then follow with OCTA and maybe one ICG at 6 months. Now it's true, SS-OCTA doesn't show you this, and especially you can't go around scanning the whole retina with OCT. So that's what prompted us to go from EDI-OCT to OCTA.
Yeah, thanks.
How do you differentiate that granuloma of TB from sarcoid on OCT angio? Is there any characteristic features?
So what Dr. Vishali was reporting, it's the paper that Ani led. We just based it on OCT and the feature, the size, but I don't believe you can on OCTA. So in our OCTA paper, we included the granulomas from TB and sarcoid, and this is just my personal impression. There was no difference at all. What OCTA can add is to look for vascularization of the granuloma for sure, but I don't think
you should use OCTA for granulomas, because OCTA is going to give you the layer-wise. It's not going to give you the entire depth. So like Francesco is saying, when you are looking at the choriocapillary disorders, which may be primary due to ischemia, which may be secondary because the underlying granulomas are compressing on them and producing some areas of flow void, it's a great tool. But you can't use it to look at the granulomas. For that, there is OCT.
I was actually very fascinated by the paper you presented on AI reproduction of fluorescein in geography.
Fluorescein, yeah.
So can you just tell us a bit more about the paper?
No, I'm not part of the study group actually. So they imaged fundus photographs basically of the posterior pole, and the AI was asked to. So it was trained with a lot of images. So generally these AI models required round about on an average 5,000 images for a particular disease type. That's the very limitation of those. And only after that you feed that it could generate. But I think there are a couple of more papers on similar models, geographic atrophy in AMD, diabetic retinopathy, amongst others.
There is one thing that I was using ChatGPT for whatever, like asking how to do coffee. And then I actually read the amount of water that ChatGPT consumes for every question you ask her, even like the stupidest question. I don't know how many liters, 10 liters of water per answer. So I just stopped. I use it for if it's really important or if I need to.
Really?
Yes.
It's not for fun.
No.
I wasn't aware of it.
So, so my wife actually told me off. So because I was using it for.
So wives are always
yes,
right.
they're always
They
right.
don't trust.
So she actually looked it up, and it produces so much heat that to cool it down, they need 10 liters per. I think it's 10. Don't quote me on this, but it's so much water for every answer it produces. So.
Yeah, I have one more question for you. Your studies on halocytes and the MLCs. How much different difficulties you face when there is minimal of a vitreous haze? And I would many of these cases.
So we have a paper out you saw the MLC macrophages like cells decreasing, and we have a paper out. It's under we're replying to reviewers. So we use you base it on the OCT. The OCT parameters. So if you get at least a scan which is 7 out of 10, then yes, you accept it. So it can have a corneal haze, it can have a vitreous haze, the lens can be opaque. All these are taken into consideration when you look at the minimum amount of quality of the OCT you get. So you set it at, it's usually 7 out of 10 for me. So you have to be pretty strict.
Yeah, thanks. I have one question for ma'am. You showed us, ma'am, Heidelberg imaging the red, green, blue, and how it was inferior, and also the autofluorescence. Do you commonly do infrared autofluorescence and blue autofluorescence? Have a comparison between that? Do you have any particular disease where you would prefer to do an IRF over a BF?
Yeah, I think those diseases are very well described when you are looking, at some of the photoreceptor disorders and few of the white dots. You do prefer infrared. So I was not focusing on that. What I was saying is that many a times, and what is happening in social media is one person puts an image and asks the entire country, what is the diagnosis? And everybody starts typing the diagnosis. It baffles me. Because suppose you have put an image which has been taken on MCI, which is not, that I did, Anirudh did, Kanika did. All of us thought the disease was inactive, and multiple times, whereas the disease was actually active. So my thing is, when you are using an imaging modality, be very mindful of for what purpose are you using it. About the infrared and all, subtle differences, yes, but they are not for the mass diagnosis. They are only to pick up few things in expert hands.
Thank you very much, and we'll leave it to the next panel.
Thank you.